Yeah, I'll take it away. Just want to kind of welcome everyone to the March meeting. And I was commenting earlier, and you all have already figured it out. But there is kind of a new process as you probably went on to join the meeting today. You have to register ahead of time, but it looks like you immediately get a link, so shouldn't be kind of an issue moving forward. But just an FYI that's the new process. Just a few announcements, a reminder that the call for proposals for CFHA ends March 15th. So if you have any interest in submitting a proposal, you have about a week left. As usual, we open this up in terms of job opportunities. So if people have any opportunities at their organization that they want to promote within the group, feel free to put those into the chat. I think those are the major announcements today. And we're actually joined by Dr. Kinney, and she is going to be presenting and doing the This Is How We Do It discussion on equity in pediatrics. So I think we'll turn it over to her at this point. And let her take away, give a presentation. A little bit later, we'll do a discussion kind of revolving the topic and the research corner.
Hi, everyone. I'm so happy to be here. Thanks for having me. I can share my screen really quick. How does that look to everyone?
Looks good.
Good. Okay. Thank you. So my name is Jessica Kinney. I work at the Children's Hospital in Colorado in our integrated primary care clinic, and I'm part of the Department of Psychiatry. And then I also spend some time in a health policy center, which is part of the Department of Family Medicine, working on policy related to health equity and access to care. So I'm really excited to be with you all today. I'm normally in clinic, so I normally can't come, but I was excited to get coverage today and be able to come. So I am going to present on equity in pediatrics today. Hopefully it's informal and you all feel comfortable interrupting me. If you all could man the chat and maybe call out if there's something in the chat, that would be helpful too. But then at the end, hopefully we can have a discussion, and I would love to hear from you all about how you're doing this work. I don't have any disclosures, and just a few really general goals today. Talk about prevalence and disparities in behavioral health care and primary care, look at drivers of inequities in our society, of which there are many, with a focus on access to care and social determinants of health, and then considerations for both, including funding. And then consider actions to advance health equity in pediatric primary care, and really truly interested to hear from you all about your experiences and current actions in this area. I also have an informal goal. My title of an apple a day, I'll go back to it. When patients don't have an apple a day to keep the doctor away. I really love creative titles, but I also am really bad at metaphors and sayings in general. So if I want to know if that metaphor lands and I want feedback about how else I could incorporate it, that's a real goal for me. Okay. So primary care is where the majority of individuals with behavioral health and suicidality concerns are seen way more than in specialty mental health centers. Before the pandemic, more than 50% of pediatric primary care visits were psychosocial or educational or behavioral health related. And I would imagine if I polled you all right now, that number would be much higher in your own experience, given the exacerbation of mental health concerns for our youth in the past almost 3 years now. Primary care covers the full spectrum of behavioral health, so prevention and early intervention, ongoing intervention and treatment, acute concerns and crises, risk assessments, safety planning, connection to longer-term services, and then ongoing maintenance and promotion of well-being. Really do and see it all in primary care. And one of the reasons for the national crisis of mental health in youth is that it's really hard to access treatment for youth. Some estimates are that up to 85% of youth who need treatment don't get it. And this is an equity issue. This disparity in need for care and access to and receipt of care is even greater for historically minoritized and marginalized groups. And it persists when you control for income, which suggests that biases and discrimination and institutional barriers are really at the core of why our system is failing to help those who need the most help. So the prevalence of mental health concerns that we're seeing in primary care is certainly related to the structure of primary care. We see kids 0 to 18 for everything, and they keep coming back. So of course, we're going to see all of these concerns, but also primary care addresses some of the barriers that the mental health system is grappling with and that have really been illuminated within the backdrop of the pandemic, especially as it relates to inequities. So primary care, and particularly integrated primary care, really addresses a lot of systemic barriers and stigma and discrimination that precludes so many youth from getting help in the mental health system as it stands now. So the burden of mental health is high. We all know this. It varies by Indigenous population and race and ethnicity due to multiple intersecting factors. I've listed some of the drivers here. This is by no means comprehensive, and feel free to add, or we can discuss more at the end. So structural barriers to accessing care. Our system is not set up for those who need it, with our policies and restrictions and wait lists and need for diagnoses and not flexible hours and insurance and geographical constrictions. Cultural differences. Where do different groups receive care? What is the experience of receiving care in hospitals versus community centers versus churches? Who do we trust in different groups? How do we conceptualize mental health, and who should help with mental health? These are all drivers of inequities based on access and availability, and based on how different people want and need help. So related to the above, this biased delivery of care, we are in a predominantly white field. Our studies and our treatments are based off of mostly college-aged white people, and those with, quote, contextual factors, also known as real world stuff, are often screened out from studies and from treatment centers sometimes too. Social determinants of health. Where we live and work and play, our intergenerational history should not affect our health and our health outcomes and our safety, but these are the main drivers of inequities in our society. Racism, whether it's covert, overt, interpersonal, structural, racism is a social determinant of health, and it leads to poor outcomes in almost every area. And then flawed data collection. We do a really bad job at collecting race and ethnicity data. We rely on electronic medical records. We constrain people to a limited amount of boxes to check. We use other or multiracial to capture a large group of people that I think is actually going to be our majority of our census by 2050. So how do we address the problem when we can't even decide who is affected and how to describe or define them? So 2 aspects of health equity that I'm particularly passionate about are access to care and social determinants of health. To me, it makes sense in my brain to come at this from a systems level as well as an individual level, because we can't ask our kids to have an apple a day and promise them that everything will be okay if they can't even access the healthcare system to tell them that, or if they don't have an apple available to them even after we tell them to eat the apple. So access to care, there's 2 worlds. Public and private insurance. In Colorado, if you have private insurance, you go to someone in private practice, of which none take Medicaid because they couldn't make a living with the reimbursement. And if they have Medicaid, they go to the community mental health center that takes Medicaid. There's a fundamental different conversation based on your insurance and therefore income, and that is inequitable. Regardless of insurance, people are being systematically excluded from care. Our current system requires kids and families to go to places where they don't typically go, to go somewhere else for behavioral health concerns instead of getting all of our needed care in one place, to pay out of pocket if they want anything different than the trainee available at the community mental health center, to be put on outrageous wait lists, to attend therapy during the day with 2 working parents and no transportation, to have a formal diagnosis, to have already gone to the ED for acute crisis, or to have, quote, failed out of one level of care to receive the care that they actually need. Primary care is the only place where they're already being seen on a regular basis, no matter who they are and what insurance, or if they have insurance. And integrated behavioral health addresses so many of those structural and inequitable barriers. We see everyone for any reason, and it's all under one roof on the same day and integrated into their overall care. And so I do believe that the only way we can have equitable access to high quality behavioral health care is through really fully integrating behavioral health services into frontline primary care clinics, and for all involved systems to recognize that primary care is frontline mental health care. This is where everyone can receive care, and I think this is where equity can start. A mental health diagnosis is a privilege. I don't know if that's a provocative statement, but there's so much that goes into a diagnosis. It means that they've already had access to care. They made it through a wait list. They were able to attend at least 2 appointments to get their feedback, maybe more. And now they have access to services because they have a diagnosis, which means that clinicians now have access to billing that can be reimbursed for a DSM diagnosis. Correct diagnosing and racism embedded in diagnosis is a whole other topic, but I do think this is an important piece of equity in mental health to keep in mind. And then lifespan and full continuum behavioral health. We need to provide access to any member of the family at the right time and the right place with the appropriate intervention, depending on where they're at. Okay. Social determinants of health. So these are the conditions and environments are upstream contextual factors that really drastically affect all aspects of a child and family's health, their ability to attend and engage in treatment, ability to heal and recover and just be their best selves. So these are things like financial insecurity, food scarcity, homelessness, transportation issues, access to food, childcare benefits, medical insurance, all of these things, family safety. And there's more and more research backing up what we as clinicians already know, that integrated primary care helps to address some of these inequities. Yes, because of behavioral health access, but likely, I think, even more because primary care is set up to screen for and address social determinants of health, which again are the main drivers of inequities in our society. I often talk to my psychology trainees about Maslow's hierarchy of needs, and just thinking about that in terms of our work in integrated primary care. If a family has housing needs or food insecurity and the kid has an elevated PHQ, an elevated depression screener, our community health navigators are probably more important than us to meet with the family. The kid's PHQ likely is at least somewhat related to the family's needs, and to address the PHQ in a silo of behavioral activation or a CBT triangle just doesn't make sense. I also want to call out that a social determinant of health that isn't always included in these screeners, but as I already mentioned, is a huge determinant of health, is perceived and experienced racism in general and in healthcare in particular. And if you all are able to customize your screeners, I would strongly suggest adding this. I also hope that another addition to these screeners is the impact of COVID-19, and especially in the pediatric world, loss of caregivers, loss of family jobs, things like that. And the only way to really know these things and not just rely on our potentially racist biases or placing the burden on the family to ask for life's most basic needs is to universally screen for social determinants of health, meaning that all people get it at some regular interval. So I think I'm a huge proponent of universal screening, and I think it's a huge way to address equity and needs at a population-based level, but I would be remiss if I didn't mention just a few considerations of how screeners can hopefully not contribute to further inequitable care. Medicine and mental health in general is based in white ethnocentrism, is in both research and practice, and embedded in a system that's both covertly and overtly really racist. The majority of the research on what we know about all types of mental health, including the very origins of diagnoses, are rooted in discrimination and oppression. And there's been very real consequences for people of color in particular for being honest about what we're asking them about on screeners, especially as it relates to the legal system or the child welfare system. And so we need to hold that in mind and remember that when someone refuses to fill out a screener, or we say that they aren't being truthful, or we feel frustrated when they're, quote, finally being honest, we're asking them to trust us in a permanent written or electronic form with what has been used against them time and time again, or with what we've asked them about before without any acknowledgement or follow-up. Another point on this is just, we say that screeners are objective, but they're still self-report and they're better than clinical judgment, but it's still about the person that's behind the screener and the people that they know are going to look at the screener. And I try to hold in mind it's really a privilege when our patients are honest with us about the hardest parts of their life, whether it's in a clinical interaction or on a screener, and the onus is on us to honor their trust and appropriately and sensitively respond. And I think relationships are the most important, no matter what the tool you're using. And the more they trust the people and the institution behind the screener, the more they'll tell us what they need. And so the more that we can help them. This is another huge and separate talk, but I will just briefly touch on. If we talk about equity and equity for kids, we're really talking about Medicaid. Kids and kids of color are who disproportionately use Medicaid. So if we want to improve pediatric behavioral health care delivery in an equitable way, we need legislative and sustainable reimbursement support for this work. Most of our healthcare is built on adults. So if we just lower the age range of our policies or our services, it's not enough. Kids are not little adults. We go from adults with diagnoses that can be billed and reimbursed by insurance to kids who need services related to family and community well-being and prevention. And all of a sudden our reimbursement mechanisms break down. So the financial benefits are long-term as our current system stands. We also need a behavioral health workforce that's able to partner with healthcare settings to really deliver the full continuum of healthcare services. So that would be reimbursed for all CPT codes. So no need for prior authorization or diagnostic eligibility or restrictions on patients. Right now, we can't bill on the support that we give family members, even though we know it impacts child health. So this, ideal funding world would allow us to treat the person how we know and conceptualize them to be, which is operating within a system and not siloed. Babies don't take themselves to the doctor, and to not be able to bill and have support to do the work that we know is necessary for the well-being of the kid and the family is really limiting. And we also need to change reimbursement so that different types of providers can bill and sustain their work in the primary care setting. So right now, any sort of care coordination, behavioral health navigator, community health navigator to address those social determinants of health can't bill for their time. So there's so many things I could have put on this slide as well. And again, curious to hear how you all think about this, but integrated care practices and healthcare systems need to build health equity into all aspects and levels of their organization. So this means not just updating an organization's mission or goals with buzzwords, but really like a clear vision with aligned incentives and resources and buy-in. Representation and compensation and provider experience for several healthcare professionals are disproportionately lower or poor for providers who are racial and ethnic minorities, are women, identify as LGBTQ, or have disabilities. And so promoting belonging and dignity and justice within integrated care settings is key to creating this culture and climate where all care members really feel welcome and valued and safe, and our patients do better when our providers are doing better, and they do better when their providers speak their language and look like them. And so we need a workforce who reflects the patients we're serving and feel supported at work to do that work. This is really individual and personal work. It's not just about a focus on our patients. It's a never-ending journey for us as we recognize how we are a part of the stigma and discrimination that our patients experience in the healthcare and mental health system, and in not receiving equitable care. I think screening for social determinants of health and trauma as known contributors to disparities is really important. And then again, we can't just screen for these things and not address them. It doesn't feel good to hand someone a piece of paper. We can't label them non-compliant when they can't navigate a system that isn't set up for them. So care coordinators and community and behavioral health navigators, I really think, are the most important team members in integrated care. Maybe second only to the community partnerships that we have that we can refer our patients to. And then back to the data piece a little bit, I think it's really important to monitor this work ongoing. So reviewing our current data collection protocols, expanding our data collection to both the workflows, place culture, and inclusion measures for staff, as well as the patient data, including race and ethnicity and language and gender and other demographic markers in an inclusive way, and then making sure this data is easily accessible and able to be looked at and shared with people. And then looking at our data, our outcomes disparate by race. It's better to know that, I think, to be able to do something about it than to not know it. So here are some discussion prompts, but really just would love to hear what stood out to you and what you all are doing in your own practices, what's working, what's hard, and then how I can build out my metaphor of an apple a day keeps the doctor away, but that doesn't make sense when it's inequitable. And then I have references I'm happy to share with anyone if they would like them.
Thanks. Thanks, Jessica. We'll open it up to discussion. If people want to jump in with questions or comments they have, you can also place them in the chat as well.
This is Matthew Tolliver. Thank you so much for that talk. And gosh, you, I think, said what a lot of us are experiencing and thinking, and you just framed it so well. So I really appreciate that. And I was wanting to get your thoughts. I mean, I work as a BHC in a really high needs pediatric primary care clinic that serves mostly Medicaid families. And we have kind of an integrated resource team as well, and are experimenting with different ways to do that. So I just echo your statements about the importance, I think, for those members of the team too. And I think a lot of times, even if those folks are meeting with our families and there's a family needs housing or needs transportation or needs, connection with community resources, it feels like I don't want to have that be a prerequisite for them benefiting from my services either. So, we'll wait until you get this taken care of and then meet with the BHC. So I was just wondering how you frame your kind of what you see as your role, or how you would frame services when folks have lots of needs, maybe some of which can be taken care of by us, but maybe some of which can't. And how from like a social determinants of health standpoint, how as behavioral health providers we can still make a difference if we can make a difference. For example, I try to think about like, how can I still help maybe the parent or the adolescent or something have a perspective shift, even given their circumstances, and still make meaning out of what's important to them in that moment. But just wanted to see what your thought about that was, and because I do agree sometimes that hierarchy of needs comes into play where it feels hard to kind of go beyond just the basic need level.
Yeah, thanks, Matthew. I really appreciate that comment and your thoughts. I think that's the beauty of multidisciplinary care, is that all of us are there in the clinic and able to help with the family and whatever makes most sense to them that day. I think family and like caregiver well-being is a social determinant of health. And I think that's a huge role we can play in terms of providing support to caregivers, no matter what the age of the kids, connecting them to their own therapy, or, just doing a mental health consult with the families that day, whether that's in front of the kids or confidential from the kids. And I think sometimes just holding in mind, like, gosh, you have so much going on, and you made it here today to the clinic, and you brought your kid to their appointment, and like providing that support and encouragement of like what an incredible job they are doing in the middle of, probably one of the hardest parts of their lives if they're having some resource needs and, housing or food scarcity, things like that. And so I think it's partnering with the health navigators, or whatever the professionals are called in your clinic that help with these resource needs, and seeing how you can kind of tackle it. Maybe you meet with the kid to see more what's going on in their world and at school and with their friends, and then they meet with the parent to talk about, concrete, where can they sleep tonight and things like that. but I think it's like an ongoing flux of working with the team. And then I think providing support to the caregiver is a huge way that we can kind of partner in those types of situations to still being helpful to the families.
Thank you.
Looks like Lisa has a question.
Yeah, thank you so much, Jessica. I really appreciated so much of your comments and just helping us all to just continue to remember how broad we need to be thinking when we're in pediatrics about all the pieces and well beyond just what's happening developmentally or behaviorally with the child. I wanted to just get your thoughts and others on the piece about data collection. It is something that we struggle mightily with and really want to really make some big efforts to have better, more accurate data. But because of so many of the barriers that you talked about with fields and all the implications that we know that are impacting why we have such poor data. So I'm wondering if you or anybody else has thoughts about how they've started to address that, and whether that's changes in EHR, whether that's changes in workflows, just what are people doing around trying to improve what kind of data we have to really look at, again, that disparity issue.
Yeah, thanks, Lisa. I can share, but I would love to hear if anyone else has thoughts first about what you're doing. I can jump in while others are thinking. We are trying to use flow sheets, which is kind of like a, I don't know if that is something your electronic medical, so we use Epic. So we use flow sheets as kind of like encounter level data to try to collect some of the things that aren't being asked in Epic when they check in or aren't like updated continually, like gender, which is something that could change. And so it doesn't make sense to just be able to pull the gender that they registered with or things like that. So I think as much as you can collect encounter level data as opposed to like patient level data, that's helpful to be more nuanced and truthful in variability. And then I think just trying to like think through and get other like expert and lived experience opinions in terms of what else should be asked, and not assuming that people in leadership know what should be asked or how things should be defined at this point. So we're kind of trying to like revamp race and ethnicity in particular, and really trying to flesh out who goes into the other and multiracial categories right now and how would they better feel represented. But I think that's like a lot of work and something that doesn't change overnight. And I think I have found that for whatever reason, data is political in academic medicine. And so there's just so many barriers that feel so unnecessary, but I think it's like worth continuing to try to push.
I'll jump in with a question. You had mentioned when you were talking about screeners, screening for perceived racism. And I wasn't sure if you were thinking about that just kind of in general or within the context of healthcare. Do you have particular screeners that you use? How do you kind of incorporate that, into kind of the, your work and following up with that, depending on kind of how people answer?
Yeah, so we have a psychosocial screener right now, and it doesn't ask about that, but it's something that I would love to include. And I think other places have examples of just like very simple ways of asking that, like, have you ever experienced racism in the healthcare setting or like in general? But then I think a consideration for that would be kind of like trauma, like, do you want to talk about it? And so not like forcing a conversation that doesn't want to be there, but like opening the door in terms of, even if it's just understanding like experiences, and to help the care team better understand and conceptualize kind of what's showing up in the room, I think, as another way to like help explain symptoms beyond the DSM diagnosis and things like that, of just like who's in the room and what does that look like in terms of their history. But we don't currently ask about it, but I would love, it's like created the screener, it got approved. And so then like next steps in terms of how to expand that, but that's on my radar.
Thanks for sharing. other people and other questions, or people, are doing this work, and kind of her question about in your practice and how it's showing up.
Dr. Kenny, can you hear me?
Yeah.
Okay. Thank you so much for the presentation. I think it was very informative. I wanted to get your thoughts. In New Jersey, I've noticed that there has been a little bit more of an uptick on school-based mental health therapists. And based on a lot of the barriers that you presented, especially, when it comes to Maslow hierarchy of needs, do you think that that would increase access, especially to children, like in that setting? I just wanted to get your thoughts on that.
Yeah, Ali, thank you. I think integrated school-based therapists are amazing and a huge way to increase access to care. I think it's especially good for kids where families either aren't supportive of therapy or like just truly cannot get them to therapy, or kids where there's like they need to do telehealth for whatever reason, but they don't have like a safe or confidential place to do the telehealth. So their option really is like schools providing them a place to sit and do therapy. So that can look like either in person with the school-based therapist or telehealth with an outside provider, but school has to like provide the space for them during the school day. So I think it's great. I am a huge proponent of expanding access and services in school, and I think those are the particular situations where it's especially helpful. I think that if it's more of like a family-based component, or they're having struggles at home but not at school, obviously that feels like a little bit less helpful. I also think it depends. So in Colorado, in the Denver metro area, our community mental health centers all have integrated therapists in most, but not all of the schools. And so those are like mental health trained professionals versus like a school counselor that is great for checking in with the kid, but might not either have the time or the training or the capacity to do more of like in-depth therapy. So I think it also just depends on like who the provider is and like checking that out if we're referring our kids to school-based. But I'm a huge proponent of it, and I think it's like definitely a part of the continuum of services that our kids need.
Thank you.
Any other questions, any comments? Anyone wants to share what they are doing in their organizations? I put something on the chat about the cultural and linguistic appropriate services, a link to the website. Our organization has a class team, and in regards to the categories for race, ethnicity, as well as the use of interpreters, we are very committed to this aspect of the inequities. I myself struggle a lot with the categories. I'm an immigrant, and I could never find myself in the categories offered to me when I have to check who I am. So I think your question about what our community can do, I think at that level we are far from having categories that are really accurate, if that exists. And I wanted to also make a comment that, at risk of being controversial, it's always uncomfortable to me that we call ourselves behavioral health clinicians. I think it's so much of a constraint to work in this way with a biopsychosocial perspective. But also, the workforce piece of adding roles that can help families navigate social determinants, how much that is also an addition to our roles, but not necessarily something that we are trained to address. Therefore, we have a lot of different names for these care enhancers that are, not even have criteria for being who they are and doing what they do, versus us who are constantly putting limits to who can be a licensed behavioral health clinician and what are the highest level of behavioral health clinicians that can exist versus the others that are less lower in the category. So I also think about those pieces a lot. And you mentioned the Medicaid versus commercial, and in community behavioral health centers, non-licensed clinicians can work, but no commercial insurances hire those. So where is, should we, open up to everyone, given the shortage that we have, versus just limiting it to the people who have, low income and have those insurances. Anyway, all those thoughts come to mind with hearing you talk about all this. And I also want to thank you for the presentation.
Yeah. Dave has a question.
Yeah, thank you, Jessica, for the talk. I think as a clinic, we are trying our best to get beyond our walls, to try and do things to engage our patients and communities. I think it's good we can post our workflows, our virtues and values, but getting people in the door to have real trust is a different story, given the kinds of institutional practices that have happened, in our community. So one of the things that we've been doing is we've been at least monthly, but usually every other week, attending a community health fair, participating with church leaders, some of the major stakeholders in the communities that we're aiming to serve. We're in the process of applying to become a federally qualified health center. And, so we also host meetings in our community. We have the third ward, which is a traditionally underserved community that's been hit really hard by COVID, as everyone has, but they were already marginalized to begin with. And so just trying to find ways to connect with that community better. We host a third ward community working group that has stakeholders from the community that come here every month to talk about those things. But I'm very curious to hear what others are doing to engage these communities and to do kind of more than just kind of have everything set up just the right way when they get to us, but how do we go out and meet them where they are?
It's a great question. And I'm just highlighting another question in the chat that Barbara asked about strategies, practices that are evidence-based to kind of decrease health inequities. So it was a great question about the research aspect, which maybe we'll be able to get to a little bit with our research corner. But how do we kind of promote and broaden this?
Also, Katie, thank you for sharing this. I don't know if you are comfortable just unmuting and just sharing a little bit of what this publication that you share with us.
Sure. So this was a follow-up to an initial claims analysis. So this is looking at 2020 data specifically, but it does offer a bit of a comparison to the 2019 data. And what we noted is that there's pretty significant prescribing differences across the payers, which isn't a surprise, right? We know that, for example, kids have so much more access to community mental health centers when they have Medicaid, and there's different services that are billable under Medicaid than what private payers will pay for. But I think it shows some clear pictures of the differences in provider types and prescribing practices of kids who are insured with Medicaid versus those insured by commercial payers. So that wasn't the intent of the analysis, but that was one of the results that we found.
Thanks so much. Rachel, do you think we should move on to the research corner? We will have more discussion time after that.
Yeah.
All right. Yeah. Well, thank you again, Dr. Kenny, for providing that really comprehensive presentation. There's so much to talk about in terms of equity. And thank you also for providing that article, which I found was a great literature review. I'll share my screen. And to Barbara's question, I think there are some implications here that the article and the presentation will suggest. Oh, there's a new share screen. Oh, there we go, I guess. Okay, this is what we're gonna have to do for today. Sorry, it just looks a little different today. Can everybody, wow. Can everybody see?
Yes.
Yes.
Okay. So this article really talks about integrated behavioral health care to address behavioral health disparities in underserved populations. Dr. Kenny really addressed a lot of things here, but really some just brief outcomes that I'm sure you all are very well aware of. You know, patients experience an improvement in their symptoms and functioning across behavioral health problems, often just after 2 or 3 appointments. Patients report experiencing strong therapeutic alliances with clinicians, especially if they're bilingual or use interpreters. And patients report high quality of care, overall satisfaction, and warm handoffs have been shown to reduce patient stigma surrounding mental health symptoms, diagnosis, and treatment. And this is really found in the general population. But when you look at underserved populations, such as Latinx, they're far less likely to access behavioral health services than non-Latinx white peers, and this disparity is only growing. Latinx women are less likely to identify a need for services and then access those services. For African American populations, they utilize behavioral health services at lower rates than non-Latinx whites, and often attribute behavioral health outcomes to family or community issues that do not require formal behavioral health support. And while they may report lower prevalence of anxiety or mood for potentially many reasons, not receiving access or diagnoses and such, nonetheless, when they do, they're more likely to experience greater symptom severity, chronic symptoms, and greater functional impairment than white peers. As far as pediatrics or racial and ethnic minority youth, we know that most children access behavioral health care through their pediatrician and at higher rates than other populations. However, for the, again, racial and ethnic minority youth, they access psychosocial services at a lower rate than non-minority peers. And again, because of access and the high cost of behavioral health care. And another thing the article really points out about is that, that presentations of depression, anxiety are different in children, which is always a barrier problem for clinicians to identify how to best treat. And that's especially so for racial and ethnic minority youth, where measures may not be properly developed to account for cultural or ethnic identity and or the degree of acculturation for Latinx children. So how can integrated behavioral health care be used? Well, it can provide a great opportunity to address these disparities by really just providing access to appropriate and culturally competent healthcare. We know that integrated behavioral health care reduces unnecessary health costs, increases access, reduces stigma and cultural barriers. We know that warm handoffs allow patients to receive brief interventions on the same day they report a problem, where potentially an individual from an underserved population may not have a chance to come back. Screenings allow for a more complex understanding of a patient, provide valuable information to all practitioners, and again, allow for earlier intervention. And we know that patients with a variety of behavioral health and mental health concerns can also be referred at earlier point, again, reducing unnecessary patient burden and cost for such minority populations. So what's next in terms of research implications? It's kind of somewhat to Barbara's point. So really, we've repeatedly called for improving behavioral health care for underserved racial and ethnic minority communities. However, limited progress has been made. Across the literature, really veteran and active duty military clinics where all the research at. There's very limited research on safety net clinics or basically communities that would not otherwise receive services. So research is needed to answer these kinds of questions specific to implementing integrated behavioral health care with underserved populations and their unique needs. And another piece the article talks about is how really research has focused on patient outcomes and less on areas of essentially the higher levels of dissemination and implementation, such as cost, penetration, acceptability, and adoption. And so maybe I can ask you guys your thoughts on this here. I don't know how to, my screen's all weird, but that's all I had for you there.
Thanks, Jonathan. I think you're kind of highlighting the point of perhaps we definitely need more research to be able to say what is kind of the evidence-based method of reducing inequities in integrated care. So
Right.
we know it's can be helpful, but what are kind of more specifics in terms of practices and things like that. Questions or comments people have about this? Choose is sharing healthy steps.
I don't know if Alice is still here, but I was thinking about the trauma screening, and I know, as I said at the beginning of this meeting, before a lot of people joined, that Ali is in New Jersey, and I know New Jersey is a trauma-informed state and has some great processes for the ACEs screening and so on. Do you want to share something on that, Ali, with the rest of the participants?
I don't know if I can share as much. New Jersey does have a lot of resources for trauma-informed care. We currently do not use the ACEs. What we do is we work a lot with the pediatricians and we educate them on the benefits of giving each patient a screening. Sometimes that comes from the parent with the PSC 17, the SCARED, the GAD, the PHQ-9, and we get a lot of referrals for that. And many times we do immediate virtual visits at the time of their pediatric physical, whatever they're coming in for, to get that patient connected with services, whether it be therapy with us, whether it be therapy with an outside provider, just to make sure that we're meeting and assessing their needs. Sometimes we have pediatric patients with eating disorders. I mean, all different kind of behavioral health needs. So we navigate that and coordinate that care. And we do use our community navigators, our case managers many times for help with that. So that's currently what me and Rose are doing in our positions as integrated behavioral health clinicians. But there are barriers, and we don't currently work with individuals with patients that have Medicaid. I think that that would be huge if we were to start doing that. But at the same time, too, we would need more pediatric clinicians to help with that need. So I don't even know if I answered your question, Maria. But I just wanted to give you a little bit of insight, like what we do here in New Jersey. And maybe that answered Dave's question of currently, how we're doing and how we're helping the patients that we come across. But there's a lot more patients that need our help.
Thank you, Ali.
You're
I
welcome.
think, you made me think about something when you responded, that this topic is also intimidating, and sometimes we don't share things because we think it's not a top strategy or something. So what you answer is great, and I encourage everyone else here to just share things that you're doing, even if you think is not an excellent way to address this, because I think what you said about the education is key. So thanks.
I just wanted to follow up too. Thanks for your question, Barbara, that Choose was answering. And I was trying to navigate my one screen today, my laptop. So it took me a minute, but I just put something in the chat just to, again, we're on a journey like everybody else to collect data on this. And I just shared what Healthy Steps, what kind of data we have and outcomes related to some of these specific efforts. So happy to talk offline if anybody has questions or thoughts about that. But I know that was a question you had put in the chat, Barbara. Sorry, I missed it earlier.
Jessica, I know we didn't get to your question on the Apple. I personally love it. I also think it came so timely because the listserv was in this conversation about the obesity guidelines, and it was on fire. And then you send your title, and I'm like, this is so much connected to our April discussion that is going to be on the obesity guidelines, and obviously, continuing with the equity conversation.
Thank you.
Yeah, I like the quote. I was trying to think about one with the apple tree or apple seed, but I think yours is better.
Any last thoughts, comments?
This is a silly thought, but one thing you could add to that metaphor, Jessica, is sometimes people do have access to the apple, but it's poisoned, right? It's toxic for some reason or another. And so just when you're kind of coloring in that example, that might be a helpful layer to add.
Yeah, I love that. We could talk about like the fish in the pond that's like dying, not because of their own problems, but the actual water. So yeah, that's great. Thank you.
I was also thinking that today we were also talking a little bit of how apples don't fall far from the trees. If we don't help parents thrive, children are not going to be able to.
Yeah, I love that. That would be a good way to pull in healthy steps too.
Yeah, I like that. I just want a reminder to everybody that the call for proposals is open through March 15th. So if you wanted to submit a proposal to present at the October conference in Phoenix, now's the time to get in your proposal.
Thank you, Jackie.